The best paper presentation prize, first prize goes to Dr. Shahana Munir. The second prize goes to Dr. Elizabeth.
Dr. Arjun will be collecting on behalf of Calicut Medicals.
Thank you, sir. Next, I invite Dr. Suvarna onto the stage to distribute the best poster certificates. The first prize goes to Dr. Urmila from Travancore Medical College, Kollam. Can somebody from the same college come forward to collect the certificate? The second prize goes to Dr. Ashwini from Amrita School of Medicine, Kochi. Thank you, ma'am. Next, I invite Dr. Sachin George, Senior Consultant, Lissie Hospital, Ernakulam. He is the Executive Committee member at AORA India. He is the member of Anesthesia Patient Safety Forum India. His area of interest include onco-anesthesia and critical care. Moderating this session is Dr. Abdul Khader, Senior Consultant, Anesthesiologist, Wayanad, and Dr. Ajnas, Assistant Professor of Dr. Mupin's Medical College, Wayanad.
So good afternoon, everyone. Before I begin, let me thank the organizers and the ISA Wayanad City branch for having me here and for the excellent hospitality they have provided for the past 2 days. And I would also like to congratulate the ISA Wayanad City branch for this excellent conference. In the next 15 to 20 minutes or so, I will be concentrating on giving you an overview of ultrasound and airway assessment. This itself is a huge topic, and it is basically more of a practical topic than a theory lecture. So what I am going to give you is a brief overview of different views you will get and the importance of these different views. And I would also touch upon how these different parameters can help you identify a difficult airway along with certain practically important aspects in clinical medicine. So I have a few disclosures. I've used a few stock images. The videos and images which I have depicted are our own unless indicated. The ultrasound machines I use for scanning, I have no associations or endorsements, and I have obtained appropriate consents for all patient related images and videos. So before I begin, I would like you to concentrate on three journals, so three articles. One is a review article, and two are one is a review article and two meta-analysis which came after 2021. My entire deliberation, my entire lecture will be based on these three articles, these three meta-analysis, because a lot of work have happened after 2021, especially after COVID on airway ultrasound, and a lot of research have been happening in India and in China, much more in China, and at least about 20 good papers have come from China in the past 2 years itself. So what are the benefits of having an ultrasound assessment of airway? As you know, difficult airway or difficult intubation or managing a difficult airway is every anesthetist's nightmare. So ultrasound will help us identify the airway anatomy, and it will help us prepare for a difficult airway if any. It helps us confirm the endotracheal tube placement. Like endotracheal tube placement, we use your end-tidal carbon dioxide or we use other conventional technique. But things go bad when we don't have a circulation happening. When we are intubating a patient with cardiac arrest, at this time, placement of the tube, the confirmation, ultrasound is of great help. Predicts post-extubation laryngeal edema. When we do morning, I was discussing with Shamshad madam, when you have steep head-on position, especially in robotic surgery, this helps us to make a decision whether we can extubate this patient or not, because we are dealing with a huge laryngeal edema at the end of surgery, and it guides real time for cricothyrotomy in emergencies. About the probe selection, we generally use linear high frequency probe for superficial structures. Certain views we may have to use curvilinear low frequency probe, and we use transverse sagittal and parasagittal views, and position can be supine or semi recumbent if your patient cannot attain a supine position. Certain views we might have to use the patient in neutral neck position, and certain parameters can be ascertained only if we do ramping or in a hyperextended neck position. The upper airway sonoanatomy, we try to visualize trachea, esophagus, the cricothyroid membrane, the vocal cords and the epiglottis. Generally we use 5 views: the suprahyoid, the thyrohyoid, the thyroid view, the cricothyroid and the suprasternal. This is a schematic diagram that depicts the different views. The suprahyoid view is generally used for oral space assessment. You can see the probe placement in a sagittal plane just above the hyoid. The probe placement will be just below the mentum. The thyrohyoid is used for epiglottis identification. The thyroid view, that is the transverse placement of the probe over the thyroid cartilage. This is generally used for vocal cord function identification. The cricothyroid view is has to be done in a sagittal and a transverse manner. This is used for cricothyroid membrane identification, helps in real-time cricothyrotomy, and suprasternal view over the trachea in suprasternal notch, which will help in endotracheal tube position confirmation. We'll come to suprahyoid view. Here you can see the curvilinear probe is placed under the chin in a sagittal manner. So this measures the hyomental distance and the tongue thickness. We will come to all these things later. So at this point, the image you see here is you have the mentum that is on the superior aspect, and you have the hyoid inferiorly, and the distance between these two is a hyomental distance. You can also see the mylohyoid and geniohyoid muscle, and you can see the tongue. So this is how you measure the tongue thickness. So this is important. You have to keep in mind the concept of hyomental distance and the thickness of the tongue. Now we come to the next view, that is a thyrohyoid view. So this is a transverse view above the thyroid cartilage. We generally use a linear probe because the structures we try to identify here are superficial ones. So this highlights the epiglottis and the pre-epiglottic phase. So this view characteristically shows something called a small phase sign that includes the strap muscles and the epiglottis. So here you can see that typically looks like a small face with two eyes formed by the strap muscles. These are the two eyes that formed by the strap muscles, and okay, you can see the epiglottis. Okay, എല്ലാം കൂടെ വർക്ക് ചെയ്തല്ല. So you can see the strap muscles forming the two eyes. You can see the epiglottis here, and you can see the thyroid membrane, and the distance between the thyroid membrane and the epiglottis is the pre-epiglottic space, and this is called the DSE, or the distance between the skin to the epiglottis. In this view, this is the most important parameter you have to keep in mind, the distance from skin to the epiglottis. We come to the thyroid view. Here the linear probe is placed over the thyroid cartilage. So this view tends to visualize the vocal cords and the arytenoids. We can also get an alternate image with by placing the probe over the cricothyroid membrane, especially if the thyroid cartilage is calcified. So you can see the vocal cords here, the thyroid cartilage and the anterior commissure along with the strap muscles. So this is important where we have to vocalize, we have to see the movement of the vocal cord, or this view is used to measure the airway edema. Cricothyroid view, you put the probe in sagittal or in transverse orientation. You follow the TACA protocol, that is, first you identify the thyroid cartilage triangle shaped, identify the airline, then you identify the cricoid membrane, and then the airline after that. And you can see the cricothyroid membrane between the thyroid and the cricoid cartilage. So when putting the probe in a sagittal manner, you can see the view resembles beads of string. So this is the transverse view where you can see the thyroid cartilage, and this is the sagittal orientation where you can see the thyroid cartilage, the cricoid cartilage, and the cricothyroid membrane in between. The suprasternal view, the probe is placed in a transverse manner at the suprasternal notch. That confirms the endotracheal tube placement, and it will typically give you the double tract sign in esophageal intubation. So this is the tracheal cartilage, and this is the air mucosal interface that you typically see. When the tube is in the esophagus, you can actually see two air mucosal interfaces. So in difficult airway assessment, POCUS outperforms palpation and all the conventional mode of difficult airway assessment. So when predicting ultrasound measurements, there are three domains you have to keep in mind. One is the tissue thickness domain, and in tissue thickness domain, the most important parameter which we have to consider is the distance between the skin and the epiglottis. The second is the anatomic position domain. Here the most important consideration should be given to the hyomental distance. I hope you remember these terms when we discuss the views. There is something called hyomental distance ratio 1 and 2, which will come later. And there is the third one called oral space domain, which includes the tongue thickness and volume. So in tissue thickness domain, what we do normally is we keep the probe in the thyroid view, and we measure the distance between skin and the epiglottis, these dotted line. And if the distance between skin and epiglottis, or DSE, is more than or equal to 2.48 at sniffing position, or more than or equal to 2.54 in neutral position, that correlates with Cormac-Lehane grade more than 2B. In APD, the probe is placed in suprahyoid view. You have the hyomental distance measured between the hyoid cartilage, the mentum and the hyoid cartilage, and this should be less than 5.29 centimeter. And if you are measuring the ratio, the HMDR1 is the ratio between the hyomental distance when the patient is in ramped position to the neutral position, and HMDR2, the ratio 2, the patient in neck in neutral position and in hyperextended position. So these HMDR1 should be less than 1.12 and HMDR2 should be less than 1.08. So these HMDR ratios indicate the reduced head extension capability. In oral space domain, we measure the thickness of the tongue. So tongue thickness more than 6.1 has a sensitivity of 75% and specificity of 72% for predicting difficult intubation. Now we come to something called DARES protocol. This was proposed by Dr. Lin et al. That is a huge multicentric report came from Texas in the United States that came in 2023. They have come out with protocol. It is still in validation phase, but I find this very, very practical in predicting difficult airway cases. So here the DARE stands for difficult airway evaluation with sonography. You generally use suprahyoid and the thyrohyoid views, and the most important measurements here we use is DSC, HMD and the HMD ratio 1 and 2 along with tongue thickness. So here first you go with the thyroid view, measure the distance between skin and epiglottis. If it is more than or equal to 5.4, it is difficult airway. You don't need to do anything else. If it is less than that, you go for a suprahyoid view in neutral position and measure the hyomental distance. If it is less than 5.59 or if tongue thickness is more than 6.1, yes, it is a difficult airway. And if it is not coming to this bracket, you go for suprahyoid extended view, neck extended view, and measure the HMDR ratio 2. If it is less than 1.08, again it is difficult airway. And if it is not, you go for suprahyoid ramped view, which will give you HMDR 1. If it is less than 1.12, you have a normal airway predicted. So we will come to conformation of endotracheal tube. So here again I told you like single air mucosal interface and two air mucosal interface when you are doing a suprasternal view, that is indicative of esophageal intubation. And in laryngeal airway, laryngeal edema assessment, it can be helpful in predicting the post-extubation stridor. So you can defer your extubation if you think that your patient may have laryngeal edema. So here what we measure is a glottis to endotracheal tube diameter. What we measure is a air column width and air column width difference. So this is like how we do it. The air column width with the cuff up, and we measure the air column width with the cuff deflated. So if the difference is very minimal, you can have a post-operative stridor, and that is how we defer extubation. In cricothyrotomy, identification of cricothyrotomy often is difficult, especially for patients like me, and in trauma when we have to do it fast. And various studies have mentioned first pass success rate as low as 36%. So forget about the TACA protocol and all. What I normally do is that keep the probe in a sagittal fashion, and you get something called string of pearl appearance, and do a color Doppler to identify the vascular structure. And this is what you get. You have the cricoid cartilage here, and just above that you have the cricothyroid membrane. These are the tracheal rings which will give you the string of pearl appearance. And you can place your needle and go visualizing the needle real time using Seldinger technique. So clinical applications, you can use ultrasound airway for pre-intubation assessment as procedural guidance and post-extubation risk assessment and cricothyrotomy preparation. The limitations, this is a new concept and it is operator dependent, because what I see may not be the assessment you get when you do the scanning, and it requires a lot of training and protocol standardization. Like I said, research is ongoing. The DARIS protocol has just come 1 year back. It is still in validation phase. So a lot of things, a lot of work has to go behind this, but definitely this is a way forward. So in conclusion, we have enough evidence to say that POCUS improves airway management, enhances safety and accuracy and speed, and should always complement with traditional methods. Thank you.
Thank you, sir. I'm going to elaborate talk about difficult airway, USG in airway management.
In fact, Dr. Arathi actually phoned me up regarding my giving a topic to me. She told me that whether can you do ultrasound of airway. I thankfully refused and told that the right person to do this is Dr. Sachin George, because I was having no doubt about that. So I told Arathi, it's not me, it's Sachin to do that. So I immediately told her that contact Sachin and he will be the right person. So I am justified now in choosing. I told you. No? So in fact, I am justified now because he has beautifully elaborated the scope or the use of ultrasound in the airway. In fact, we had a case, I think 1 or 2 weeks back, following laparotomy case. I think it was a rectum case. It was a little bit prolonged, some additions and there. And post-operatively, we extubated, and the patient went to, not stridor actually, it is gradually becoming like desaturating and breathless. So we could not find the cause. There was no sound of any vocal cord palsy actually. So then later on we intubated because we could not, she was desaturating. So we intubated again, and then overnight, after overnight ventilation, next day we again extubated after putting a exchanger, because we expected some laryngeal edema and all. There was no reason definitely to focus on laryngeal edema. So we extubated and found again it reappeared. So again we reintubated. So then we did a fibrotic bronchoscopy, because we don't ultrasound. We are not that much good in doing ultrasound of necking, assessing the airway. So we did a fibrotic scopy and found out that there was arytenoid cartilage edema at that level, not the cord level, at the arytenoid cartilage level. That may be the reason for this breathlessness. So now I could really appreciate that. We would have done an ultrasound, and but we don't know actually how to use it. That's why I could not use it.
Picking up laryngeal edema or any of the tracheal cartilage, the edema can be easily picked up with ultrasound. So we are routinely using it for our robotic surgeries, where the surgeon always will want the patient to steep head down, and you're looking at a surgery that typically goes for about 10 to 12 hours. And at the end of surgery, we definitely will have cerebral edema and airway edema. So this ultrasound of the airway, prediction of the ultrasound edema, airway edema, has helped us to extubate otherwise patients we would have otherwise normally kept on ventilator overnight. We could safely extubate such patients. Sir, as I said, like all these things are being validated. So we are like consolidating our experience and what we learned. Every day there is something new which we learn.
Thank you, sir, for your excellent presentation. As you told, there is new papers coming after 2021 from China and India. And in my alma mater, JSS Medical College, Mysore, we have already done a paper based on USG ultrasound.
Yes.
And we conducted like our parameters included distance from skin to anterior commissure vocal cord and epiglottis and thyroid membrane. And we found it like, we did it in obese patients, and the distance cut off were like 1.1 centimeter. Yeah. And DSAC was like the most accurate thing in predicting difficult laryngeal.
Again, good you brought up that point. All these papers that come from China, their anatomic parameters are different from
Indian people.
So when we do these, when we try to validate the studies from China, we always get slightly higher values, because they are short statured and the airway is like slightly shorter than ours.
Actually, we went through the papers like you mentioned
Yeah.
before, and we coordinated according to the Indian population and
Yes,
did this
yes.
study. Sir.
That is the need of the hour. Like lot of people, especially like Indian, a lot of institutions are coming up with new parameters, new indices. So that's actually very nice.
Thank you, sir.
Thank you, sir. Now I request Dr. Abdul to kindly come to the stage to felicitate Dr. Sachin. Next, I invite Dr. Suvarna K to the stage to kindly felicitate Dr. Abdul Khader and Dr. Ajnas. Thank you, ma'am.